blood pressure is high. He was on a triple medication without a diuretic. Discussed the issue of pulse pressure, but we didn't touch so far about the other organ damages. Let me give you some information on that. One is that the ECG and chest X-ray were quite normal in the patient, no abnormalities. Microalbuminuria was detected, it was measured by the urinary albumin-creatinine ratio, which is about 140 milligrams per gram, clearly elevated. Normal values are between 30 and 300. Serum creatinine 1.3 milligram per deciliter, which is at the upper normal limit of a normal range. Now, because, and I think you are all aware of that serum creatinine 1.3 milligram per deciliter could be misleading. Usually you get the calculation from the lab of an eGFR, estimated glomerular filtration rate. Have you any idea how much the glomerular filtration rate in this patient? The lab gives you the value, but you maybe have already some kind of feeling. 72 years old, male subject, serum creatinine 1.3. Any guesses?
45.
60.
How about his weight, Roland? The question is, how about his weight?
Yes, the weight can tell you. Actually, I didn't know it by heart because the weight does not go into the formula. But if you want to know the weight, it was, no, I have it not here. It does not go into the formula. The beauty of the MDRD formula, which the lab uses, does not need the weight. Just the gender, male, age, and measured serum creatinine level. So 62 was, that's right, I heard you correctly, 62 here on the left side, on the right side?
45.
42 we had here.
42, okay, well, actually I did it just yesterday because I noticed throughout my presentation I forgot to calculate it, so I went to the available formula, which is available on the internet. It was 54 comes up. Actually 54.3 is the value which the MDRD formula gives you. So this means we are below the border of 60, formally, or not formally, also in reality. This patient has chronic kidney disease stage 3. What does this actually mean? Does this change our behavior? Now, first of all, let me show you this summarizing figure which calculates the risk in this patient. And as you can see here also, the terminology has a little bit changed. On the x-axis, well, it works, here we are here, you see the albuminuria stages. You see the term high albuminuria, meaning previously called microalbuminuria. The term is now high because the word micro means it's a minor problem, which is completely misleading. This patient has a problem. If you have albuminuria between 30 and 300, and this is the previously called macroalbuminuria, now called high. You can see here the eGFR stages. This patient fits into that, meaning stage 3A, mild to moderate chronic kidney disease. If these, as you can see here with the risk of this patient, orange, not completely red. So also seen from this slide here, you can see that the eGFR stages and the albuminuria adds up to each other. Now, knowing that, the question is, does this change our strategy to treat this patient? And again, we discussed it early this day. What about the blood pressure goals? How far should we lower? We discussed elderly patients, 150, yes for sure, because it was a fit elderly, below 140. This was our conclusion this morning. Now that this changed in face of the new information we have, cardiovascular, no organ damage, not detectable, renal parameters, microalbuminuria, actually, which is a vascular parameter, and eGFR, stage 3 as a parameter for chronic renal failure. Does this change where we should treat how we should treat and to what target?
Any thoughts from the audience?
Who starts? Somebody else starts.
Just yell out.
Or we can say 150, 140, 130, and maybe ask to the...
Somewhere there in between. So what is your guess really at the end?
Let's say 140.
140.
140.
Okay.
Anyone for 130? Any hands of raise of hands? No one is more for 130.
No one for 130? What about if the age would be 45? Are you then going for 130?
Well, 1 year ago.
1 year ago, okay. You are too well educated, I'm sorry to say that. You know the changes of the guidelines well. I will tell you, I looked at all guidelines available, published in the last years, and I can show you, actually, you have been quite right. Look at these numbers which are depicted here. You see, first of all, the numbers. US guidelines below 140/90. No separation whether there's microalbuminuria or macroalbuminuria or not. Then European guideline says if proteinuria, meaning macroproteinuria above 300 grams, then you should go below 130/90. The Canadian guidelines say 140/90, not separating between micro, macro, or whatever kind of albuminuria. The Kidoki guidelines say, well, if CKD and proteinuria is evident, you should go below 130/80. So clearly, well, as a person who has participated in the European guidelines process, I go for the European guidelines, and it's clearly up below 140/90 because the patient has not yet developed overt proteinuria.
Roland,
Yep.
can I stop you at this stage?
No problem.
This target, this new target, are based on which kind of studies?
This is really a good question, and fortunately, with respect to that, in the nephrology community, we have 2 studies where really the patients have been treated to different target blood pressure. That's the optimal study design you can go for, and these data are based on, therefore, and that's why some pick them up as European or Kidoki saying, if you have macroproteinuria above 300, then you need a lower blood pressure goal, systolic 130. If not, 140 is enough, meaning below 140.
Do you agree, Roland, that these targets are derived from study, from retrospective?
No, sorry.
Analysis?
Fortunately, we have 2 prospective studies called MDRD study and the AASCAR study, prospectively. They are highest level of evidence. This time it's fortunate, we are fortunate.
But this study, what are the goal of this study?
The goal was the primary objective, not any drug, but the goal. And this is the way we should have more studies also in the cardiology field. Precisely.
There is a lot of controversy about this.
Well, the controversy is not so much, I think, overall. You just see that some really have a closer look to the data and came to the conclusion, yes, because of these prospective data with the primary objective, a target blood pressure, that we should go below 140, namely below 130, if proteinuria is evident or not. The others didn't. Sorry to say that, like the US guidelines or the Canadian, didn't check carefully their own data.
In this context, again, we have Dr. Dowd around the corner. I hope this time he brings in the right question. And his question is,